So we're talking about cognitive behavioral therapy for school-age kids and adolescents with problematic sexual behaviors.
So one of the questions that we get a lot is what is problematic sexual behavior in children versus what is developmentally typical behavior? So how do you kind of address that, or how do you answer that question for people?
So, looking at it for school age kids, it's more so it's curious, would be typical and developmentally appropriate. It's spontaneous, there's nothing that's forced, it's not coercive. No one is at risk, there's no safety concerns at all in those types of typical and developmentally appropriate situations.
And with adolescents, we're looking at same age range. We're looking at romantic relationships rather than coercion in terms of developmentally appropriate sexual behaviors.
So what, with adolescents, what defines it as problematic? What are the keys, things that you're looking for?
Yeah, so with adolescents, we're looking at any illegal behaviors. We're looking at coercion, we're looking at aggressive behaviors, sexual behaviors, and we're looking at behaviors that are not responsive to parental redirections.
So it's interesting that that's very similar to what we see as problematic for school age kids as well, because we're looking at a lot of this, some similar things, right? Like, it's problematic if it is, like you said, if it's forced, if it's coercive, if it's aggressive, if anyone's put at risk, at danger.
Yeah, it's really that those three areas of frequency, intensity, and duration. Right?
Absolutely.
So, how frequent are these behaviors occurring, or is that problematic in of itself? If it's excessive, if it's not responding to typical parenting interventions, how intense the behaviors are. That we're looking for things that are well beyond what children of that age range should know about, what kind of actions are well beyond that. And then also just how long this lasts past the parenting intervention.
I really like our handout that we give out to identify, to help parents identify what's problematic versus what is developmentally appropriate.
And for adolescents, there's also if there's any sexual exploitation, that can be included in the category of problematic. It can also include sexual behaviors towards pets or animals, as well as stealing any intimate clothing of others. And so there is a broad range of what kinds of behaviors fall into these problematic sexual behaviors.
Well, and I like the fact that you're bringing out the broad range, right? Because we're talking about youth problematic sexual behaviors, right? So we're not necessarily talking about the traditional ideas of predators, or we're not talking about these traditional ideas of coercion and that kind of thing. That can be included, but this can also just be other behaviors that are intrusive or not meeting social norms. That's a lot of what we're looking for, and it sounds like you're looking for the same, is the social impact these have. If this includes really intense emotions as well for either child involved.
And with adolescents, there's oftentimes a stigma that there's an attraction towards younger children on the part of the adolescent, and studies have shown that that's actually really, really rare. That oftentimes the problematic sexual behavior, even if it includes a younger child, is driven by other forces.
Yeah. Well, and that kind of also, to kind of flip it to the other side, it also includes sexual behaviors that kids are doing with themselves, right? Like not just behaviors that may include another kid. So excessive masturbation or excessive porn watching, I mean, would also fall under those problematic behaviors as well.
Yeah. So especially with kids, it seems like there's an increased risk of exposure that is leading to some more problematic sexual behaviors in kids. Would you guys speak to that a little bit?
Yeah, so especially school-age children, they're very curious.
Yes.
And one of the shifts that we've seen over the last decade is kids are having more access to technology, It's becoming more normal and typical for children to have cell phones earlier and more often, tablets earlier and more often. And so, because of this, kids are getting exposed to more adult topics at younger and younger ages. There's been a shift over the last 10 years where the majority of children, the first contact or first exposure to pornography tended to be closer to adolescence. And recently that shifted to more school age. So sometimes children as young as in the 9 to 7 range are getting their first exposure to these online, to pornography and things online.
So that it's all part of the increased risk due to exposure, and talking about the stats on pornography and exposure in children, and then just increased monitoring and how, having open and consistent conversations about sex and what's healthy, what's not healthy, what's appropriate boundaries, and just realizing that it's not a one time and done kind of conversation, that parents have to, as uncomfortable as it may be willing to have those hard conversations. And one of the things that we do is support parents in having those conversations and figuring out what they know versus what they don't know, and helping build their skills so that they do feel more comfortable having those conversations.
And I think that leads us really well into talking about what PSB CBT treatment is. Do you guys want to share some about the school age treatment?
Yeah, so our group is mostly a group model, primarily a group-based model. It's an open group, meaning that families can join at any time, but it consists of 6 modules, and each module teaches a new skill to the family to address these behaviors. And we run 2 groups at the same time. One is for the caregivers, one is for the children themselves. And so we're helping the parents to feel supported in having these conversations and teaching these skills. At the same time, we're teaching the children the same skills to address impulse control, emotional regulation, so that they can make better choices when they have the impulse to engage in PSB.
And for the adolescents, it's a very similar setup. So it's also an open group where families can enroll at any point in time in the group process. And we are meeting with caregivers and the adolescents. But instead of 6 modules, we have 12 modules. So we're working with the 12 modules is supposed to take about 6 months. And then we usually repeat that with the same families to really ensure that they're diving deep into the material and learning the skills.
I think one of the important things too to recognize with the groups is just the effectiveness of the treatment, right? So based off of the research that has been done 10 years out, it's 98% effective, right? Which I don't know about you, but there's not too much that I do at 98% effectiveness, right? So just understanding that it's not a label or a behavior that's got to follow these kids forever. It's something that can be addressed in a timely manner, and skills can be taught to help reduce the behaviors that you're seeing in the moment as well.
Well, and I think that's a really good point, is problematic sexual behaviors in school age kids and adolescents is a very serious problem. And there's a lot of hope that this does not have to be something that follows them throughout their entire lives when they get the treatment.
Well, and I just keep getting stuck on that number, right? So 98% of children that go through this program will not have any further PSB after 10 years. So this is an extremely responsive population. This is an extremely effective treatment.
And that's for both school age kids and adolescents. So what about the referral process? If someone is having a concern about this behavior in their adolescent and their school age kid, how do they get involved with this treatment?
So the cool thing is the referral can come from anywhere. Anyone can make a referral for kiddos to access PSB services, they would just need to reach out to our senior leader and complete the referral paperwork, and they would be contacted by someone on the PSB team.
So by anyone, teacher,
Teacher.
parent, social worker, kid themselves,
Absolutely.
DJJ worker,
Other providers,
Mhm.
other mental health providers.
a doctor.
Yep.
Okay.
Yeah, anyone that's involved in this child's life that sees this as a problem or wants more information. And that's the beauty of the referral process, is that starts this conversation, that starts this dialogue, so that one of the team members can do this assessment and decide if the group treatment is necessary, or decide if we should be giving parenting skills to help the parent navigate this conversation. There's multiple routes once the referral has been submitted.
So, what does PCIT consist of?
So PCIT consists of two different phases. The first one is CDI, or child-directed interaction. This is where parents will learn to strengthen the parent and child bond through positive attention, praise, and play. It focuses on warmth, following the child's lead, and reducing negative attention. Once we are done with that phase, we will move to parent-directed interaction, or PDI. This is where parents will learn to give clear commands and consistent consequences, such as timeouts, and reducing some of that negative attention.
So, how do these sessions work?
The way sessions work is the therapist coaches the parent in real time through an earpiece while the parent is interacting with the child in the playroom. Parents are able to practice the skills and receive immediate feedback and support.
So, what is the goal of PCIT?
The goals of PCIT are to reduce child disruptive behaviors such as aggression, defiance, and those meltdowns, while also increasing positive behaviors and emotional regulation. PCIT is also perfect for strengthening attachment and improving family communication.
So, TFCBT stands for Trauma Focused Cognitive Behavioral Therapy. It is an evidence-based treatment designed to help children, adolescents, and their caregivers process and recover from traumatic experiences. It integrates principles of cognitive behavioral therapy, attachment theory, and family systems theory, with a focus on both trauma processing and skill building.
So what is the goal of TFCBT?
So the goal of TFCBT is to reduce trauma-related emotional and behavioral symptoms. So correct distorted or unhelpful beliefs about the trauma, like self-blame, guilt, shame, strengthen coping and safety skills, communication skills, and really to support caregivers in responding effectively to trauma-related behaviors.
What are the core components?
So the core components are practice. So P is psychoeducation and parenting skills. R is relaxation skills. A is effective expression and affect regulation. C is cognitive coping and processing. T is the trauma narrative and processing. I is in vivo mastery of trauma reminders. And C is co-joint child caregiver sessions. E is enhancing safety and future development.
Tell me a little bit about the structure.
So TFCBT is short, tends to be 12 to 25 sessions. It involves both individual sessions with the client, parallel sessions with the caregiver, and then at the end, joint sessions to strengthen the communication between the two and to reinforce progress.
What's the approach?
So TFCBT is skills oriented and phase based, beginning with stabilization and coping, moving into trauma processing, and concluding with integration and future safety. The therapist maintains a balance of sensitivity and structure, helping the client regain control over trauma memories and rebuild a sense of safety and empowerment.